our first question, maybe Dr. Whiteside, I'll ask you to weigh in on how you've experienced change in the healthcare system and how that momentum has kind of affected you and your operations.
I think whiplash would probably be the best description. The change has been swift and in multiple directions. So everyone saw technology transforming the way that we deliver healthcare, and I'll talk about mental health care since that's my area. But change comes slow. There's lots of barriers in terms of the technology, regulation, payment models, provider and patient comfort with it. So it was coming slowly, and then all of a sudden we needed to get it up and running in a matter of a week or two. So we at Mayo suddenly switched from all inpatient appointments to all virtual appointments, and then a little while switched back to mostly inpatient, face-to-face, and now we have switched back to doing a hybrid model. So these changes were coming, and I'm sure these changes will remain with us. We've also been looking at how we can use, in addition to telehealth, how we can use websites and apps and platforms to get information to our patients. So it's been a swift change that was a long time coming.
I imagine, and I know from some previous conversations, Melissa, you've also seen kind of a rapid set of changes within your organization and your groups.
Sure. As CVS as a whole, because we're retail and pharmacy, you need to be present. But we have gone to mail order, significant mail order, or home delivery for free. Telehealth is up 300%. We needed to be nimble and agile internally and externally. We have 350,000 employees, and we needed to make a secure connection to the network. Therefore, most of the people who went to the office now work from home for the safety of individuals and to prevent COVID-19. It's been interesting. It's a lot of work, but it also made us streamline, be agile, follow safe methodologies in order to spin up systems and applications from a front door perspective to make the employee experience great, a 360 degree, as well as the customer experience and a 360 degree.
And I think we've had some great questions kind of along those lines from the audience. I think that some of these changes that you're mentioning, how do you think that they'll persist? How do you think that they'll stick around? Do you think we'll go back to kind of the normal that we had before? Or do you think that some of these whiplash items will continue to stick around? And how do you see that impacting your businesses and your operations?
Sure. I think that you'll see many, especially the millennial generation and the younger, the digit generation, I think they'll continue with telehealth. I think you'll see more of the baby boomers somewhat in between, some liking the telehealth, some people wanting to have that FaceTime with their physician. And then the elderly community seems to want to have the doctor visit, be present, what they're currently comfortable and used to. And the blessing is that we can be nimble and we can offer what our customers want and need.
And I don't know, Rick, I imagine you've gotten different kinds of requests from different kinds of customers over the last several months. Both, what do you think about how those have come in, the speed and pace, as well as do you think that they'll persist and now you're expecting that to be the new normal going forward?
Yeah, the velocity of the needs and the requests and the variance of those was something I don't think we could have ever expected. We had probably over 100 unique requests for help. Unique meaning that each example of where an organization required help was somewhat different, right? Telemedicine, telehealth, right? That was quite obvious. What was interesting, I think most organizations have been down this path of digital transformation for a long time as they try to pull aggregate data together to gain insights, gain value from the data. I think what we're finding is that leveraging AI and ML, while it was a nice to have in the past, if necessity is the mother of invention, COVID has become the.
Yeah.
You can jump in, Justin.
Yeah,
See what we say.
just to tack on to that point with Rick is that we've seen an unprecedented amount of integrations between.
Oh, I'm having bad internet.
A little bit. We got most of the content, I think, near the end. I'll help you out. We'll let you know. Don't worry about it.
Fair enough. But so the adoption, I think, of AI and ML at a more mainstream level is starting to take off.
Mhm.
And the ability to access.
For you too.
Yeah.
I was trying to tee you up, Rick, when he came
Thanks,
back.
buddy. I got to tell my kids to get off their Xbox.
We've just seen an unprecedented level of integrations in the healthcare system that has not existed before. And within health systems, it would be a multi-year effort just to integrate new tools from some of the EMR vendors. And now we're seeing this down from years into months. So really excited about the velocity and how that's going to improve healthcare interoperability, because that's going to allow what Rick mentioned, more of the AI ML components that can sit on top of those services, because we're starting to slowly see that silo break down between these healthcare environments, because just getting data, as Melissa knows very well, just getting data is 80% of the battle. So really excited to see that continue to grow on as in-person visits start to ramp back up.
Yeah, you know what's, to pile on to that, what's really interesting is we're starting to see large HCOs come together, sharing data across organizations, which in the past you would have thought was not something that would be deemed possible, or, quite honestly, being open to it. So I think COVID has exposed the idea that across industry, we can solve this problem together. If we try to tackle it ourselves, our ability to solve it is going to diminish.
Yeah, it's a little bit like the space race. We're trying to get on the moon, so we're coming together on previous teams and nations that otherwise would not have been bipartisan efforts. So really excited to see how other ACOs and other organizations are coming together to be able to solve these problems. And what we're learning is that it's not just a disease-caused problem. There's a lot of external factors, whether home environment, socioeconomic conditions, and other demographic data that lead into that. And that's actually going outside of the healthcare stream, which I've been most excited about, seeing how genetics is finally starting to come more mainstream and how we effort that. Some of the cloud providers like Google, obviously Rick, and being able to offer those services that healthcare organizations could take advantage of these new data streams that otherwise have never existed before. So I really do see that we're going to have a Cambrian explosion of sorts of thought process and knowledge-based learning in the healthcare industry for the years to come.
Absolutely. That's where an ecosystem is so important for any healthcare entity, to follow one's entire healthcare consortium from beginning to end, and having machine learning and artificial intelligence and Internet of Things be able to track and monitor and educate so that individuals or companies can make educated decisions and make the next right step. There was a situation where an ecosystem was developed, single sign-on, API integrations, big data, collection and aggregation, where there was a patterning of individuals who were getting sick. They were getting sick with cancer, which triggered an event for the EPA to come in, because it was observed that everyone on this cluster happened to have well water. And it was discovered by the EPA that the well water was contaminated, which triggered another event to get these individuals in this cluster onto city water. And so you were forever changing the trajectory of these people's lives, because a cancer cluster was discovered through the contaminated well water, and it was mitigated through the collection and aggregation of disparate systems using APIs and following within regulatory compliance a healthcare journey. I think that using like health pieces, like Google has Google Health, that can be an instrument of great use in order to change people's lives, in order to educate people, in order to help people make better decisions about their own lives. You know, similarly to if somebody is sick all the time and they're going back to a mold infested apartment. Social economics, we've also discovered through machine learning, through artificial intelligence, that plays a big role. And we see that in COVID-19 as well.
No, I think that's, I think it's an interesting connection. I'd love to dive in there more. One point of logistics, just for the folks participating, we're going to use polling throughout the process. So you might see one or more polls pop up, or maybe you already have. Love to get your feedback on some of those questions as the panelists work through the continued announcements. We have some active questions from the crowd, so I'm pretty excited about those. So maybe we can pivot topics just a little bit. We've got a good one from Rob. Let's take a look. Is Rob on the line? Are we gonna unmute Rob? Otherwise, I've got his question pulled up. There we go. Welcome, Rob.
Hi, thanks for letting me talk. I was wondering if anyone had any experience or had seen telehealth utilizing 3D modeling or 3D photogrammetry in order to give providers a model of what people were experiencing at their home. Has anyone seen anyone in the telehealth space utilizing 3D modeling?
3D modeling meaning the landscape of a home, or 3D modeling based on a condition set?
Like with orthodontist, if you were doing a 3D model of your teeth rather than going in the office, say.
I personally have not seen a demand for it, nor have I been a part of the conversation. I will tell you that I've been a part of telemedicine, telehealth conversations to the tune of probably 20 or 30 a week with various customers, and that's not one area that kind of has been honed in on.
Sure. Interestingly enough, I've heard those conversations through research institutions, as well as universities that have a medical practice, you know, be it Cornell, NYU, MIT, and so forth. But I have not seen it in corporate America. Not to say that it wouldn't bring value in corporate America. Maybe it's a little too progressive for some of the enterprise companies that do the adoption not first, but perhaps second.
Yeah, the only thing I've seen is on COVID, they actually genomic sequencing. I've seen there be a lot in the 3-dimensional, more of a data visualization, but then also on the compounds and actually visualizing structures. I've seen that sector explode, especially some of the geneticist friends that I have. It's been very fun to see how they've been able to visualize very, very complex, you know, down to the protein level, how these things are interacting with each other. And Johns Hopkins has released a lot of that data as open source. So that's been really great to see the data science community really start to analyze that data. But that's been the only example I've seen. I've seen a little bit done in the pathology space of trying to visualize how we could send tissue samples. But obviously that's not directly like a 3D modeling perspective.
And I think in previous conversations, we've talked about how some medical device arenas have spun up, either having devices in home purchased by customers or provided possibly by health systems. Are there any other uses of that, or how have you seen that? Do you expect that to have an uptick? And I know, Dr. Whiteside, in your area of practice, it might be more about tools than physical diagnostic instruments. So I don't know if you have a perspective there about how those tools can become more useful within homes.
Yeah, in in general, in medicine, there's a kind of a concept of the least restrictive environment to treat someone. So if you can treat somebody with an outpatient visit, you don't bring them into the hospital. And I think COVID-19 has affected that in two ways. One, there's an increased risk coming in, so you don't want to bring people in as much. But then also with the growth of digital health, there's just a new, less restrictive environment to treat people that you can give, especially with mental health, you can do an evaluation pretty much just as effectively via video as you can at home. So why would you not offer that? And as someone who probably does not go to the doctor enough and is never particularly excited to take my daughter to the doctor when she needs to go, any option to be able to treat things or get it evaluated without going to the doctor would be wonderful. And so we have been kind of thinking about, I think many people have, is how can we use self-help tools through websites, through apps, have been exploding for a long time now. And one of the challenges is research keeping up to technology and innovation, because there's a lot of options out there that are probably not evidence-based and probably not particularly helpful. But for many people, a little knowledge and a little support and a nudge in the right direction is sufficient to help them make some healthy changes for their mental health or for their physical health. And the more we can do that with digital information, asynchronous communication, the better. And it's not a replacement necessarily for coming in and see the doctor or having a face-to-face video or in-person interaction with the doctor, but you can extend that interaction. You can get things started with a traditional meeting and then use digital tools to support them on their journey.
I think that's great insight. And that question came from an audience member. So I wanted to make sure if there's any more to that question. I don't know if we were going to ask Matt to clarify that. I don't see him quite teed up yet, but Matt, if there's more to your question, make sure that you kind of type it out, and we'll make sure we get followed up. I think next we can move on to a couple more audience questions. You guys are doing a great job. We've got a few teed up in the chat, but again, as you think of something, feel free, put it in the chat. We'll also work on, again, after the Q&A, there's a mixer portion if you can stay. And I know everybody on the panel is very passionate about getting their question answered. Oh, there you go, Matt. If you want to add any more insight or depth on your question, I think it would be, make sure that we've answered it holistically.
Unmute.
Looks like we're just waiting for Sam to, if you can pop Matt off of mute. There you go.
Yes, sorry. No additional comments. Thank you. That's good.
Yeah, no problem. Thanks for joining. So I think from there, maybe we can move towards a couple of the other questions that I see in the chat. We've got, oh, there we go. Go for it. I don't see your question right now, so if you want to, once I pop you off mute, we'll let you know and you can ask the panelists directly. Looks like we're still working on it for a second. Give it one more second. If it doesn't look like it'll pop up, I can also read a couple of the, you can go ahead and unmute. You might own the rights to do that now. Doesn't look like I can do it for you. Okay, maybe we're having a little trouble there. We can keep working on that. I see somebody else has joined. Looks like John, if you have a question you'd like to jump off mute, I think it'd be a great connection to where we were just talking about help at home. I think you should have the ability. There you go.
Can you hear me?
Welcome. You should be unmuted.
No?
Oh,
Yep.
Now we can. There you go. Yep.
So we have a population. We have populations in rural Pennsylvania where broadband internet is not robust and somewhat non-existent. These populations can actually benefit from telehealth and other medical devices, but the infrastructure is not there. And I was just wondering if anybody on the panel has heard of successful, cost-effective alternatives to getting technology specifically for medical use to these populations.
Very interesting. I have done some government work, state, local, and federal, and no tech zones, especially in the Midwest, were popular. And what the solutioning was is that all of the local libraries became tech zones, or a particular town became like a Google town where they had, you know, dark fiber and offered the internet. It would require an individual to leave their home, and during COVID-19, that may be a risk to them. But that was the solution from a government perspective until they could get some type of dark fiber or some type of other medium, maybe satellite, into that particular area. And then a lot of people would tether using their cell phone in order to connect to a network securely.
Thank you.
Going back several years, I've seen telcos offer their hotspot devices for areas at risk, more of a senior rural-based populations, as the example I was a part of. But they actually offered, as part of the hospital, they went on a joint venture for the devices for free for these people that was needs-based, that they were able to get these devices and hotspots to do not just telehealth, but after someone had hip surgery, a patient that had 2 levels in a rural-based population that was over a certain age, let's say 70, they were much higher risk for having a readmission event. So they actually had to intervene with them to help them with their recovery as well. So I definitely see, obviously, a broadband is ideal, or a Google Fiber or something high-speed internet, but I see hotspots as a really good way to kind of get started with some of the remote-based telehealth services. They don't require a ton of internet bandwidth either.
And Justin, what we're actually starting to see more of,
Thank you for that.
the community wants to leverage their smartphone. Yeah. So Justin, we're starting to see communities leverage their smartphones more so than, you know, a true device, whether it's a Chromebook or Windows laptop, whatever it might be. So leveraging your cell communications and leveraging your smartphone seems to be a widely used and now more adopted model. But I think, to Justin, your point, we're starting to see the payer community and the provider community wanting to provide at-home equipment to support the needs of patients with MS, stroke patients, or other physical disabilities, to accelerate telemedicine, telehealth, and the complete exposure 360 view. I think I'm breaking up again.
That was a great, no, we heard you, Rick. A little bit of video issues, but answer was great. I do think that we've seen the mobile expansion as well, either device connected via mobile or mobile direct. So thanks for that. Thanks, John. That was great. Oh, go ahead, Scott.
I would just reiterate what Rick said, that you know, in kind of my experience with doing telehealth, probably it's more common for people to be on their phones than on a computer. I was talking to one mother who was taking a break from work and was talking to me on her phone in the bus that she drives. No one else was on the bus. Research, you know, also when we were putting together some grants for some telehealth, some app-based interventions, basing it on mobile smartphone application actually helps increase access to underserved populations, because many of them rely on their phone as their main computing device. They don't have laptops or desktop computers.
Very true.
Yeah, the telco device example is a little dated. It's about 5-7 years old now, but I definitely think, especially with 5G coming up, our interface between telehealth and our providers is almost going to be exclusively cell phone based. Google's been very smart, you know, with Google Fiber, but then, you know, also offering a cell phone service as well. I know some small business entrepreneurs that just use the Google cell phone plan just for their data plan so they could stream as well. So that's been interesting to see.
And from a healthcare perspective,
great uses of those technologies to try to. Go ahead. Go ahead, Melissa.
Go ahead. From a health perspective, what we've done to accelerate the patient care is so a patient's safe during COVID-19 for any infusions, whether it be for MS or dialysis or cancer, we go to the patient's home now instead of them coming to the center where they could be further at risk. So we're trying to mitigate risk as best as we can and provide awesome customer service.
No, thanks. Great insight from everyone. Good question, John. Looks like we've got another question from the audience ready up. Brian, I think you're unmuted if you want to go ahead and ask the panelists.
Sure. Hi there. One of the things I saw working in healthcare, just on the medical record side, you have quite an assemblage of different coding standards for payers, pays, finance, EX 12837s and all that, just on the billing side, to the medical record side, where I've even seen within one standard like the HL7, I worked on a project where a hospital would be making requests from a lab, and we had to translate within the HL7 their requested test to be what the lab expected, and then the lab results, we had to change the coding they used for the results to what the hospital was expecting. And they're all simple mappings, but it seems like obfuscation for no good reason is counterproductive. So do you see, as a possible outcome of this, a streamlining of all the fairly Rube Goldberg coding that is in place?
I can take a first stab at that. Within the AHL7 platform, I've been, been on that for over a decade now, but I've really seen, getting in the weeds of every system uses OR, UORM messages as the highest level very differently from each other. So I see more of a standardization of the fire protocols on top of that can help that transmission go a little bit faster. But the hard part with an HL7 is think of it like a breadboard, is that you still have to put the templates within inside of it. And there's not a lot of standardization around that. I do believe that's largely been driven to not as much adoption, and I really see this uptick increasing that. And I also am excited to see the EMR vendors are really starting to put HL7 native-based connectivity in the application itself. I think part of the problem is that they had to take the data out of the EMR into another system, and then that system had to talk to the wherever you're trying to move the data, and now they're trying to reduce that pipeline activity, which I'm really excited to see, because being able to generate X37s directly from an HL7 message previously was really hard to do even 2-3 years ago, and I've seen that streamlining effect it's been very positive to see. So having been in the weeds with you in HL7 messages going back a while, it's great to see that we're starting to standardize what that looks like. Melissa's the expert on this because she deals with this every day, even more than I do.
I do. And Justin, that was perfectly said. I could not have said it any better than you. But I agree, because we actually have a client right now, a very large client that we work with. This was topic of conversation yesterday. So it's heightened priority today. I mean, we need to do something universally, even nationally and internationally.
Definitely.
I'd be interested, Dr. Whiteside, as well, from a clinician perspective, how, if that impacts you, or from a health system, if you focused within a standard set, and if you don't see as many impacts in a patient-facing environment as we might see in the back end, trying to connect multiple patient-facing environments together.
Right.
But
I mean, the revelation we had was going from IC9 to IC10. That was progress.
It obviously, I was part of that transition, and just knowing how CPT codes fitted in all that and being able to work with diagnosis codes, it was a big shift. The one thing that I want to add on top of this that I've been excited to see is how we actually can help billing improve from an HL7 messaging. obviously X37s, but obviously, Melissa, this is your world. But I hear a lot from the provider side is that I have to interface with 5 payers on any given one moment, and all of them have a different templating system of how I get data to them. So they have a hard time based on the adjudication process. They can't actually verify cost ahead of time. They have to wait for the denials and rejections come into place. So from an HL7 perspective, I'm really excited to see how machine learning can help anticipate rejection-based claims faster to help that process go, because we see so much inefficiency of just the negotiating every cap table for that and being able to drive that into revenue for the provider, but then also cost savings for both the provider and the payer that will ultimately go down to the bottom line with trying to lower the cost of overall healthcare and our GDP.
Absolutely. And PAs, we're working on sophistication and robustness with our PAs, prior authorization, to minimize any of the denials, the rejections through adjudication. Yes, we definitely need improvement in the industry as a whole. We definitely have taken a concerted effort to work with our partners and to work internally to fix what's systemically broken.
Okay, thank you. Those are great. I knew that one would be, we get a couple of you very interested. So thanks for performing exactly as expected. I know that there's another question from the audience. It looks like Manohar, you've joined as well. So I think you're unmuted if you want to ask your question.
Yes, so 2 questions. One is probably going to be a controversial question about contact tracing. So how many of you think that this will be a feature built into our mobile, phones going forward? Although that might kind of develop on some privacy and other concerns. And the second question is more in terms of the machine learning as we know it now. How do you think it'll be applied to accelerate drug development or any kind of a genomics or any kind of a acceleration of drugs without compromising on safety? And this I meant mostly for Rick, given your association with Google, but up to anyone.
Yeah, no pressure. Thanks.
Yeah, exactly. Thanks.
On the contact tracing question, I'd go back to one of my original comments around necessity is the mother of invention. 6 months ago, I would have never thought that Google and Apple would have come together to try and solve something of this nature. I can tell you Google's extremely sensitive to the information that we have. So for us, if we continue to expand on this effort, right now it's just Bluetooth connectivity between Android and iOS. It's being made only available to the government, not to private sector in any manner, shape, or form. But it's going to be completely opt-in. If you would like to participate, you have the ability to participate. If you don't want the ability, it is not something that can be turned on. And with how much pressure around sensitivity of data there is with Google, obviously we're being hypersensitive to that. On the genomics question, it's a great question. And I think AI and ML are already providing incredible value to the healthcare community in whole. What are we doing specifically? I don't know if I can comment on that at large, but we are working with organizations like Verily, part of our Alphabet organization with Project Baseline. We have the ability to opt in and participate in clinical trials. But the machine learning and AI models are certainly going to be leveraged to fast track vaccines, drug development, and accelerate clinical trials, in my personal opinion, not necessarily that opinion of Google.
Melissa and I are both just like chomping at the bit. We can't stop smiling with this question. So I will go after you. Melissa, you go. I just wanted to call it out that we're both super excited about this. So
absolutely. I mean, the advancements in technology, robotics, artificial intelligence, machine learning, Internet of Things, 5G, I think will rocket us into the next dimension. To really help save lives or cure things that we couldn't. There's a company in Israel right now that actually is working on that to develop a coronavirus, COVID-19, a vaccine, and they've actually taken the animal vaccine and they're altering it to see if it's safe for human beings. And I do have great hope that that will be released to public for clin trial soon. And if we want to piggyback on that, remember a long time ago, the FDA used to approve many drugs per year, and then due to lawsuits and liability, they reduced it by 50%, in some cases 70%. Perhaps this new revelation will open up opportunities to relax regulation in some instances in order to streamline drugs from coming to market. You know, a long time ago, you only did 1 or 2 clin trials. Now you seem to be doing 7 clin trials before the FDA will approve it. Now you see 10 drugs a year being approved by the FDA. You used to see 25 to 35 drugs a year. So I think that we're going to see a pivot in medicine overall. And, you know, regarding tracing, it's very interesting. There are ways to do it within compliancy. You can have a golden record, a single source of truth, a matching algorithm to decide that you are Joe Smith when you go to, you know, the doctor or you go to the pharmacy to have your prescription filled. And these are some of the things that we're using at our company. You know, we don't want to make mistakes. These are human lives. Not saying that we've made mistakes, but, you know, we take extra cautionary approach when we're dealing with a human's life. You know, drug interactions are very critical and high priority for us.
Yeah,
I appreciate that. I think that, well,
Yeah, one other comment on that, and I guess this would almost be a question for the panel as well. We're seeing a large uptick in requests from HCOs to do just-in-time appointments, leveraging geo-tracking and mapping technologies to identify when a patient has arrived in their parking lot so that they can have a concierge service come out, greet the patient, bring them in directly into the room and not have to wait at all, right? I don't know if anyone else is seeing that request, but there seems to be a big uptick from the HCO community asking for that type of capability.
Yeah, we've seen a huge uptick of that with the clients we're working with. You know, we really see this term patient experience pop up time and time again, that this isn't just you check in, you give your insurance card. You know, myself personally went through a little bit of medical tragedy earlier in my life, that every time we had to go to a doctor, because the data and the systems didn't talk to each other, we had to rehash it with every nurse, with every doctor, with every surgeon. And what a horrible patient experience is that. So now we're looking at this more as it should be like more of a retail-based experience. It's about how you feel, how you interact. It's not just the pretty pictures on the wall. It's actually helping them feel like you're in charge of your control. You know, to kick it over to Dr. Whiteside, you know better than anybody with Mayo and how you're working with patient experience and, you know, integrating the overall patient care, but also how they integrate with the health system. And it's not just a transaction anymore, it's a relationship. So Dr. Whiteside, what's your opinion on that?
Well, I don't know that I have much to add. I think you guys are exactly right. But I would add that it's just not kind of a consumer preference satisfaction variable. It also relates to outcome. And especially if you're hospitalized and you have a better experience and you have, you know, a quieter room where you can sleep more and you have your emotional needs met, it helps with improvement. So it's important on a number of different levels.
Yeah, outcomes are, it's a heavy topic.
Yes.
No, I think we've talked a lot about partnerships. I think I'd like to spin on those just a touch more. A lot of our partnership discussion right here has been barriers broken between different vendors that maybe don't previously, you didn't think about talking to each other. I was interested, and not to cause too many questions right away to Dr. Whiteside, but I was interested in partnerships across specialties. So I know a lot of the work that you're focused on is how do you make specialty care available to folks in other settings. And how you think the digital transformation aspect of that can make that easier or can hamper that, and what's critical in that space.
Yeah, you know, that's a great question. And there are lots of different pressures on healthcare and lots, with specialization, it takes more training. It takes longer to get in. It's more expensive. So there's lots of pressure to treat things through primary care, and a lot of those things can be treated well there. But there is a reason that people specialize, because they have more experience and different options. So it's a balancing act. And once you get into I think one of the strengths that we have at Mayo Clinic is that we're so integrated, not only with the medical record, but just the culture of the practice, that we can communicate well together. And so, and I don't think everyone has that luxury. If you are a specialty practice, that's not specifically linked to the other primary care or specialists, it's hard to have that communication. So I think technology can help a lot there. I think another partnership is just between healthcare and technology. I was going to mention with the medical record, medical records have to do so much, and it sometimes feels like a provider that the provider's interface is kind of low on the list of things that are being prioritized, that the medical record can do so much, but it really adds a lot of burden in steps and clicks, and things that you never had to do before, because now we're trying to document care, get clinical information out of it, schedule, etc. And so having the user as part of that development process, and being involved in we are not experts in technology, so we may have ideas of what we think would work well, but we don't know how to implement them. And sometimes when solutions get implemented, it doesn't work so well in real world practices.
Anybody would be frustrated. I was just going to say, anybody would be frustrated when they had to log into 11 apps every single day for their job. So doctors, that is my largest complaint I hear, is streamlining the interfaces that we, having worked at a healthcare startup, this was many years ago, but we were super excited. We got in front of the doctors and we didn't even make it 7 minutes in the presentation. They're like, I'm not signing into this, so I don't care what it is. I'm not signing into it. And I'm like, holy cow, what do we do? So, just really that interface it's both a patient experience, but it's also a provider experience, because it's that relationship that you want to accentuate, because that's also ultimately what's going to increase outcomes for the overall system.
Yeah, great. Well, we're getting close to the top of the hour here, so I just wanted to probably do a last call for question within the Q&A portion, and then give you some of the logistics about the follow-up session. So Rob, if you want to go ahead and ask your question, welcome. I can pull it up if we don't have Robert available here. His question was related to
I didn't realize you were talking to me.
There you go. Sorry. No problem.
Well, there you have it. Let's see.
Bring us home.
Okay, I don't have it in front of me, but the gist of it was that you mentioned solving the problem of the medical record from a national or international perspective. That seems like a big ask. Who do you see as spearheading or overseeing or guiding a process like that, or are we destined to wait until the market solves it, however long that takes?
From an international standards perspective, sorry, Melissa.
No, go ahead.
International standards are more SNOMED based. From a United States based with ICD-10, I would say creating a crosswalk to make those two systems. But obviously, I would strongly urge that it's not obviously one nation, but then that becomes a hard part about any international thing, is it does become political by nature. So I would say it's better to stress on the topic at hand, like a COVID base, so that it's a team effort. We're fighting towards the same goal, rather than a more international movement to help solve something just to solve it.
Thank you.
Sorry, Melissa.
No, I concur. I also think that you'll see large tech companies streamlining and helping, partnering with various healthcare companies in order to produce these capabilities, the enablement. I mean, we definitely need to modernize and transform. Resiliency is key, as well as privacy.
Absolutely, all good points. I'm just curious as to, it seems like such a sea change from where we're at now, where everybody has their own idea of what a medical record should be, but I'm not seeing a lot of
unification.
People merging those ideas together into a single platform. Everybody seems to want to pursue their own way.
Sure, and I think that's where the API becomes the strength, because that's the whole purpose of APIs, is to connect disparate systems, collect, aggregate, and disseminate data. So I think where we have those gaps, we can utilize secure APIs within the API framework and standards to ensure that the data is shared from these disparate systems.
So it has to be led from the technology side to create a framework that's going to allow the integration.
I think so, but I also think that through various proof of concepts and presentations, that the medical community will have a greater need and want for this feature or capabilities.
Yeah,
Thank
and a
you.
plug for the Google Healthcare API that's been in general release. Having data that can both be PHI and non-PHI heavy, I think has been the hardest problem from an EMR perspective, is how can I share data with other organizations and, you know, mask the data. Whereas something like an API that's run by Google, they look at it from the pipeline in a very agnostic way, rather than it being an EMR heavy medical record perspective that you can mold it to what you need it to be. So, you know, finding agnostic partners in this game, EMR vendors as a whole, they've done a lot of contractual differences over the last 10 years, but, you know, having that data be moldable, that you could allow it to be shared, that is both PHI and non-PHI heavy.
Right.
Should we take a pause? I think Dr. Whiteside, I think Dr. Whiteside, you had a comment you wanted to make.
Well, I just wanted to add a little, thank you, Rick. I just wanted to add a little wrinkle about ownership and that kind of historically medical records have been owned by the physician, by the provider or the hospital, the medical center. And I think there's going to be more of a demand that patients want to own their data. It's their data, it's their health. And so then that may, I don't know who's going to lead it, but that may push kind of a sea change in medical records so that it's patient oriented rather than provider institution oriented.